Next, thank you, madam, for your kind presentation. Next speaker is Professor Dr. Ragini Parekh, madam. She hardly requires any introduction in Mumbai itself. That she is very versatile, helping and sympathetic, empathetic, and compassionate to the doctors, budding doctors, as well as to the patients. She is known from apart from her presentations and publications. I recognize her, or whole Maharashtra, apart from Mumbai, recognizes you for your contribution in the state towards the eradication of the cataract program. I know she is the fastest cataract surgeon and dare to do the surgeries 100 and 125 surgeries in a day. That's why I recognize you, madam. Next, you. Thank you, madam.
Yeah. Yeah. Thank you, Manoj Dada, for such a lovely, lovely introduction. You made me very emotional. We've known each other for 30 years, and it is all because of a Marathwada teacher that I became what I am today. So I think the credit goes to Lahane sir for making me who I am. So my teacher, Padma Shri, Dr. Lahane sir, my sisters, Dr. Namrata Sharma, Dr. Mohita, Manoj Dada, my brother KP, very dynamic guy, and I want to see you as an MLA soon. Rishi Bhai, Himanshu sir, Satyajit, Dr. Vibhuti, everybody, Dr. Bhatti sir, RC sir, who are my teachers here, Dr. Manoj Mathur sir. This time I'm not going to let you bunk BOA. So, and everybody, Shalini and everybody present here today. Shriram is my classmate from my first MBBS days. So nice to see you here. So we have been seeing why the patients are we've been seeing unhappy patients, and we'll now see what makes them unhappy. So now cataract is a catarrefractive surgery, and the patient expects a lot, has googled a lot, has heard a lot. So the patient and the doctor both wants the patient to be more than 90% within plus or minus a diopter or cylinder. A plus one diopter miss is not a satisfactory result. So, what happens and why is the patient unhappy? And what really happens is that the, Mohita has so well discussed the effective lens position, and we really, don't consider that the rexes would make so much of a difference, but it does. So, errors in calculation of eggshell length, even a 1 millimeter change would change the refractive position of the patient, keratometry, ELP, which we've already seen, and formulae. This we have all seen. So there are five pillars which stand between the patient and a perfect result. We've been seeing that in the last few talks. So the patient expectations are very, very high, like Sir said. So if you're operating 4, 5 patients, one patient has before surgery opted for a monofocal lens because of his finances. And the other patient has opted for a panoptics lens, Alcon, and is paying a lot of money. What happens is that they discuss, and then the first patient comes and tells you, "मुझे नजदीक का तो दिखता नहीं है." You've already told him nahi dikhega. So then one day I was telling Lahane sir that we should segregate the patients. That we should have lists in such a way that monofocals are on one day because then they will not discuss with each other. The ocular surface is very, very important nowadays. After I won the tear check machine and we've been using that for a lot of patients, we realize that there are so many factors in the tear film that we were not aware about, and it became important to me when we wanted to operate my father. Every time we checked him, the reading would be different because he has chronic dry eyes, and the cylinder would change. And then we realized simple things like the Shermer. Even before the Shermer, when I feel that we are dependent on optometrists, but the first thing and the simplest thing, if you don't have topography and machines like tear check, if you see irregular Myers while you are doing an auto ref, that means the patient has severe dry eyes, and the patient would have a changing cylinder even in the auto ref, forget in the IOL master. So that should put your antennae up, and the T-bar and so we do Shermers for most of our patients and all the patients who undergo cataract surgery, if necessary, topography and stain. Biometry has already been discussed, that today it has become very, very important. When we were starting a new clinic and when Sir was spending so much money for the IOL Master 700, I didn't really realize because I took it for granted when we were in JJ. And today I know that it is one of the most important thing to have or own because it gives you an accurate result. IOL calculation formulae are very, very important. And so many surprises that you may have post cataract surgery if the patient has a macular hole. And even if you know that the patient has some macular problem, the patient's expectations will be high. You tell the patient that we are doing this surgery because we need to treat you later on for your diabetic retinopathy or something. But the first question the patient will ask you or tell you next day is कि मुझे नहीं दिखता है इसके जैसा. Even after you explain. So, as we all know, and we've been discussing, that you have to know the person before you choose the lens. And like Sir has already said, that we have refused a lot of patients. So, you have to screen and you have to set realistic targets. So, the most important thing, according to me, today is the ocular surface. We see patients who have a very, very bad ocular surface, whether they are young or old. The young, because of the digital strain and they have severe dry eyes, and the old, because of the age, with the tear film, the meibomian gland problems, or the comorbidities that they exist. So, irregular drying surface scatters the keratometry Myers and report a false K, and a wrong K becomes a wrong IOL power. So that is very, very important. So that is why 77% of the cataract patients have dry eyes. It's true. And many are underdiagnosed. So many patients come to us with having great surgeries performed by other surgeons, but with dry eyes, and they're extremely dissatisfied. So I think that first we used to just say slit lamp, keratometry, A scan, pre-op, blood investigations, cataract surgery. Now this has changed. So you have to do, and you have to check your ocular surface, and you have to, there will be changes, and that you may wrongly measure the astigmatism, which may or may not exist if the dry eyes is correctly treated. So I think that these are necessary workups, and you do not need specific instruments or a big setup for doing a Shermer's or tear breakup time. Even an autorefractometer will show you the distorted Myers, staining the ocular surface, and if necessary, a topography. If we have an OCT, or if you don't have access to an OCT, the AS-OCT will pick up the early topography changes. So that may be very, very helpful. So what you have to do is you have to treat the surface, optimize the patient first. Don't get scared of losing the patient, because if you do not optimize the surface, you will have a post-operative dissatisfied patient. So you have to optimize it, re-image it. So after optimization, you will find out that the A scan results are completely different with respect to the cylinder or something like that. And then you have to decide, if you have stable reproducible readings, only then should you operate the patient, not only for a premium IOL, but even without the premium IOL. So we've already discussed the biometry, the ultrasound, applanation ultrasound, or we have the IOL Master 700 in mature cataracts, immersion ultrasound. So we have a rule in our clinics that at least one A scan of a particular patient before going for cataract surgery is done by the surgeon. Means in my clinic, I do it. In the other clinic, Sumit does it. And even in when we were in JJ, we used to have senior optometrists doing the A scan or senior residents. So, like this has already been discussed by Vavikar, that you have to have, and the ELP has been discussed by Dr. Mohita. One more thing is that we take these A constants for granted, and you have to be very careful, and you have to evaluate yourself continuously. So we had two patients who were sleeping on their stomachs. One because she had a back problem, and on day one they were 6 6, and one patient with one eye, he had -3, and I thought that something may be wrong because he was troubling and the lens was anteriorly placed and the rexis was larger. But in the other eye, he had it. And then we found out that he was sleeping on his stomach. So before the wound sealed, the lens was actually moving forward. So that affected our, and so you have to evaluate. You have to evaluate what went wrong in a particular patient. I had four patients who, because I'm a Jain, had a low B12, and these patients were 6 by 6. with, and later on had a drop in vision, cystoid macular edema, and there were no reason for it. We got the B12 done. The B12 was extremely low. Just giving them and supplementing B12 and giving them nepafenec eye drops improved their vision to 6.6. So you have to evaluate what went wrong, and you have to. So now in one or two patients, I give them B12. So, and if the patient has more than one cylinder, then it is mandatory. But one, I would like to caution over here that we had a patient who had a financial problem. The cylinder, when you send it for calculation to the company, they say कि नहीं नहीं toric ही lens है. The cylinder was not so much, but somewhere near one, and the patient was not paying. We put in a nice small Rexis and a monofocal IOL. The patient was not only 6.6, but the patient had N10 also. So, you have to be beware that whether the patient actually needs a cylinder. They might be, while calculating, putting in surgeon-induced astigmatism to a certain extent. So, beware of people who want to sell toric IOLs. If the cylinder is very large, be very careful of your positioning, because large cylinders with a little bit of rotation makes a very, very unhappy patient. Small cylinders with rotation, the patient will not complain. So in larger cylinders, your, like Mohita said, your axis has to be really, really measured. You have to ensure that your lens doesn't rotate even by a few degrees. So these things are very, very important. And if you feel that something is wrong with higher cylinders and all, a topography is a must. So here I will tell you that there was a very big man in Mumbai, a priest who is no longer there, so I can discuss this case. A very, very big man who was operated for a cataract and then had a high cylinder. So a piggyback lens was used, not satisfied, came to sir, and we didn't know what was happening. And we thought that we would dial the lens, but somehow or the other, we did a topography. And even in an 80-year-old, we found that only in that eye he had keratoconus. So sometimes, if you have a very high cylinder or fluctuating readings, then it is worth doing a topography, which may cost only 1,000 rupees, even if it is not at your clinic, but to save. And retina and endothelium. So you have to do OCT or you have to check the retina, because that may cause an unhappy patient. Thank you so much, sir. Endothelium is important. And so counsel, optimize, biometry, topography, calculate, screen retina, and then operate. Thank you.